today. We're very excited to have a three-part presentation on different advancements in research aimed at immune or acquired TTP. The level of these slides are aimed for practitioners or hematologists, those working in the field, but we do encourage everybody to join that would like to, and we're excited to engage in some great conversation here. So our first presentation will be given by Senthil Sukumar at Baylor, and I will bring him to the stage and hand over control.
All right. Hello, everybody. Thanks, Claire, for putting this together and assembling this group. So we appreciate it. I'm going to start off my talk with just talking some about the long-term complications of TTP and some of the advancements therein. So without further ado, all right. So how do we diagnose, a thrombotic microangiopathy, or when do we suspect this in general? So typically, you're going to need a few, key clinical features in order to be suspicious for an underlying TMA or thrombotic microangiopathy. And the first thing is going to be microangiopathic hemolysis, or essentially evidence of microscopic red blood cell destruction in the vessels. And you'll see that with schistocytes on the smear, evidence of usually a severe thrombocytopenia in the case of TTP, and polychromasia, so different cells at different ages. And then you'll also typically see ischemic end organ damage with the acute presentation. And in TTP, this predominantly will be affecting the heart, the brain, and or the intestinal tract. The kidneys can be affected, but tend to be less so than other types of TMA in general. So thrombotic thrombocytopenic purpura, or TTP, is an exquisitely rare condition. So it's about 1 to 3 per million per year in terms of incidence. And it tends to peak in African-American women who are about 30 to 50 years of age or in the third, fifth decades of life. Different conditions like pregnancy can precipitate episodes. And if left untreated, this is greater than 90% fatal. And so it's really important to have a high index of suspicion when a patient presents with this constellation of symptoms and have a high degree of suspicion for TTP in general. So how does TTP occur? Typically, you have an enzyme called ADAMTS13. This is made by the liver, and this will cleave ultra-large von Willebrand factor multimers. And so these multimers are typically secreted by the endothelium as these long strings. And what ADAMTS13 is supposed to do is it cuts these down into normal physiologic sizes that are active at a physiologic level. However, whenever you have antibodies that either functionally inhibit or they may promote the clearance of ADAMTS13, you have an abundance, an overabundance of these ultra-large von Willebrand factor multimers, and that can cause platelet ultra-large von Willebrand factor multimer aggregates, and these will form microthrombi in the capillaries and small vessels of these different organs that I mentioned earlier. That's what causes the shearing of the red blood cells as well as end organ ischemia. So you'll have some additional talks on this later at the end of the meeting, but the current landscape for the acute treatment of TTP includes plasma exchange, which removes autoantibody and then replaces a normal amount of ADAMTS13, and then as well as caplacizumab, which is an injection that was approved in 2019 by the FDA, and this helps prevent microvascular thrombosis. It helps increase platelet count recovery quickly, and then it also can reduce exacerbations while you're on it. And then immunosuppression is also another central pillar of acute treatment, with steroids and rituximab often given in the frontline setting. And we continue the plasma exchange until the platelet count's at least 150 for 2 days. The caplacizumab should continue essentially until ADAMTS13 recovery above 15 or 20% most often, and the immunosuppression can take several weeks to occur. So here's the landscape of TTP treatment over time in the last 101 years now since TTP was first described. But initially, the mortality rate of TTP was over 90%. And with the advent of plasma exchange in the 90s, this greatly reduced to less than 10%. After ADAMTS13 was identified in the late 90s, when we began to understand that this is traditionally due in the majority of adults to an autoimmune phenomenon against this antibody, prednisone and rituximab greatly reduced our mortality rate. And then now caplacizumab's reduced the mortality rate to 4%. I think the formatting of the slide is slightly off, but in that red box should be the 4% kind of seen above the plasma exchange there. So as more people live, as people become long-term patients, we have to shift our thinking a little bit. Previously, TTP was seen as an acute illness, and so the patient's discharged, so they're back to baseline, right? Well, we're not so sure, and we've now learned that long-term sequelae in this patient population is unfortunately common. So up to 40% of patients can have PTSD or depression and other mood disorders, and similar percentages of patients can have neurocognitive impairment, chronic kidney disease, hypertension, obesity, stroke. These things reduce quality of life, and you can also see an higher all-cause mortality in this patient population when compared to normal controls within the general US reference population. So I'd first like to highlight some cardiovascular complications that these patients can face, and one of those is stroke after recovery from TTP. So in this study performed at Johns Hopkins, TTP survivors were found to have a higher rate of stroke during clinical remission of their TTP when compared to age and sex match reference populations. What this means is that in a cohort of about 200 patients who were followed long-term after their TTP diagnosis and they were in clinical remission. So importantly, their platelets are normal, their ADAM-TS13 may or may not be normal, and there's no evidence of an active TMA occurring. And strikingly, 13% of these patients were found to have a stroke throughout the course of their long-term follow-up compared to just 2.6% of traditional patients in the reference population from databases that are available in the US. So some of these explanations could include traditional risk factors for stroke in general, like cardiovascular disease, hypertension, obesity, and lupus. And we also don't know, does stroke during an acute episode increase risk for a future stroke? And what about the ADAM-TS13 activity in remission? So we have some precedents from the general population that low ADAM-TS13 activity can be associated with increased rates of cardiovascular disease, stroke, and mortality. So in this population study, which was done in just under 6,000 patients from the Netherlands, it showed that patients in the lowest quartile of ADAM-TS13 activity, which is this black line here at the top of the right figure, with a median activity of 70-something%, had the highest incidence of stroke. And these are patients that are completely normal, don't have TTP, and have no von Willebrand issues. And they were still found to have, as the ADAM-TS13 activity decreases, the incidence of the stroke increased. So when we compare the ADAM-TS13 activity in TTP survivors with stroke, we see a clear separation of the curves, and TTP survivors with reduced ADAM-TS13 activity are 5 times as likely to experience a stroke during clinical remission than survivors with higher ADAM-TS13 activities. That cutoff of 70% was chosen based on the prior study I just showed you from the general population of the Netherlands, where they showed that 70% seemed to be that cutoff. We also looked at major adverse cardiovascular events after a diagnosis of TTP. So we defined major adverse cardiovascular events to be heart attack, stroke, or any need for cardiac revascularization. And we noted that these events occur at an increased frequency in TTP survivors compared to the reference population. The most predominant is going to be stroke, as seen in the figure on the left, followed by non-fatal MI, revascularization, and then fatal MI, which occurred in only one patient, fortunately. Strikingly, the mean age at first event was decades younger than the reference population in the US. So the age at first stroke for women appeared to be around 49 years of age compared to 56 years for men. And this is nearly 20 years younger than would be seen in the US reference population. And the early 50s was also when first MI was seen compared to the US reference as well, again being in the 60s and 70s for men and women respectively. Here's a breakdown of our patient cohort versus some other large population studies that were done in traditional cardiovascular cohorts. So in patients with established coronary or peripheral arterial disease, compared to patients with established atherosclerotic risk factors, or in patients with genetic predispositions, you can see that our patient population, highlighted in the red in the left-hand column, are generally have a female predominance. They're almost 20 years younger than these traditional cardiovascular populations. And we also have a higher percentage of Black identifying patients, which also reflects the epidemiology of TTP in general. And the rate of major adverse cardiovascular events is double that seen in even some of these most traditional highest risk patients among the US. So we had about 24% compared to about 14% in these other very high risk category groups. Another thing from the Johns Hopkins group is that silent cerebral infarction is very prevalent in TTP. What silent cerebral infarctions are they are essentially infarctions or stroke events that occur and are detected on MRI imaging in the absence of any overt neurological deficit. So there's no clinical neurological signs that are detected. However, these patients will still have evidence of some infarctions on brain MRI. And up to 50% of patients in the Johns Hopkins cohort were noted to have silent cerebral infarctions, and this is significantly different compared to just 16% of controls. And when they looked at the association between silent cerebral infarction and major cognitive impairment, it's clear that silent cerebral infarction is significantly associated in particular with major cognitive impairment, as seen here by the green bar graph. This could explain why some of our patients have evidence of progressive neurological cognitive impairment as things go. And apologies, I guess, about the thunder. It looks like it's a storm rolling through Houston here. What this presents, though, is an earlier time point in which we might be able to detect when patients may develop clinically overt symptoms. So we know that there's going to be a group of patients who are at risk for cerebrovascular disease. However, we need to continue to develop additional diagnostic algorithms so that we can hopefully detect patients before they develop overt neurocognitive or overt stroke and neuro deficits on clinical exam. TTP survivors are also at risk for premature death, and we can see that the overall cause of mortality increases as time goes on in a TTP cohort compared to the adjusted US population in the black compared to the red graph. And when we examined causes of death in TTP survivors, and again, these are causes of death during clinical remission, and so the patients are otherwise healthy without issues, we notice that there's a twofold higher increased mortality noted in our patients compared to the reference US population here in the orange. The major cause of death after recovery from acute TTP was cardiovascular disease, and this was reflected in both the Oklahoma registry as well as a combined cohort from Johns Hopkins and Ohio State, followed by TTP relapse as being the number 1 and 2 causes of death. Some risk factors for early mortality in our patients include male sex, increased age, and an increased number of TTP episodes. But remarkably, traditional risk factors weren't reflected in the multivariable model, and so this raises questions: are there TTP-specific risk factors which may contribute to mortality? When we look again at this ADAM-TS13 cutoff of 70%, we see a separation of the curves. However, the numbers of patients who experienced mortality in follow-up was fortunately small, and so this didn't reach statistical significance. So what are some factors that may influence these different types of events? And we know that age, diabetes, race are associated with the development of major adverse cardiovascular events, but this is likely multifactorial. And even things like race, we have to understand, is a social construct and may only reflect the underlying inflammatory or other changes due to chronic stress that may be occurring. So some of the potential hypotheses for why vascular disease appears more predominant in TTP survivors may be from this reduced ADAM-TS13 that we see during clinical remission. Perhaps there's ongoing subclinical injury due to increased ultra-large von Willebrand factor multimers or microthrombi. things that can increase endothelial damage in both the heart and the brain. The higher frequency of African American race, autoimmune conditions, or traditional risk factors is also seen in our patient population, and it may simply be that these factors themselves increase the risk in our survivors. Accumulating injury during the acute events may also explain why the increased number of TTP episodes may be driving this, and there may also be other drivers of vascular injury or inflammation that are seen in patients with underlying autoimmune conditions that may contribute to this. This does beg the question that does preventing additional endothelial damage during an acute episode potentially improve these outcomes? And we'll talk about that more later during a discussion on acute therapies. The last study that we'll leave you with is one that we've recently done at Ohio State, where we examined cardiac MRIs, stress perfusion tests very specifically, in TTP survivors. And we examined this in 15 survivors compared to just normal controls who received a cardiac MRI for another cardiac indication, but who had normal stress perfusion. So there were no differences in the rest perfusion seen here on the right. And perfusion is specifically, it's a heat map. So the more bright or yellow or the color looks, then that's the more blood perfusion going through the myocardium. And when we look at the stress images, on the bottom, we see the control patient who has the entire wall of the myocardium lighting up very nicely. However, in the top row, we can see that the TTP patient has less perfusion in the subendocardium specifically when compared to the control patient. What this really tells us is that there were significantly reduced myocardial perfusion reserve. That is a number ratio that essentially demonstrates the heart's ability to relax and to have the coronaries fill up to their maximum potential. And this is impaired in patients with TTP. And this occurred really regardless of what the ADAM-TS13 activity level was in remission. And this signals to us that these patients likely have some underlying endotheliopathy or vasculopathy that may be contributing to these cardiac and stroke events that we see. So the take-home messages here are that TTP survivors are at increased risk for heart attack and stroke, and this may be related to reduced ADAM-TS13 activity in remission. TTP survivors should be followed longitudinally to importantly prevent relapse, but also address some of these long-term complications. And we really need to make sure that we're addressing these underlying risk factors and modifiable risk factors for cardiovascular disease specifically. And we should be screening and aggressively managing these, even in patients who may not traditionally fit that mold of a 60 or 70-year-old male smoker, kind of vasculopath patient. But more so the young woman patient who may come in with TTP even in their 40s, and you may not traditionally think of having as cardiovascular disease. We need to make sure that we're aggressively screening and managing those patients for these complications, and just to develop good partnership with our PCPs and other cardiovascular specialists. And then I think, Claire, you can correct me. We're taking questions at the end, probably. But that'll do it.
That is correct. And I'm going to open the Q&A function here on the side so that we can start gathering the questions now, and we will focus on answering them as best as we can at the very end. So that should be available on the right-hand side for anybody joining us under Q&A, or if you would prefer, you can use the chat function, whatever is easiest for you. And with that, I'm going to take you off the screen. Thank you, Dr. Sukumar. And I will bring up Dr. Spiro Cadlin. Just one moment. All right. We're getting a little preview of Spiro's slides there. There we are. All right, Spiro, you're on stage.
All set. Great.
All set.
Thank you, Claire. Thanks for the invitation to do this and present to the group. And thanks, Senthil, for a great presentation. Really on an important topic of long-term complications in patients with TTP. I'm going to talk about something a little bit different. I'm going to bridge this gap between TTP and HUS, if you will. Remember, the term thrombotic microangiopathies refers to, it's a clinical finding. It's a condition of either pathologically small clots in the smallest vessels, but leading to a low platelet count, organ injury, typically kidney injury. So it can be used as a pathological term as well as a clinical term, but we also use it as an umbrella term to really cover multiple etiologies or conditions that can lead to a thrombotic microangiopathy. So as you can see here, TMA is the clinical finding, and you've got some specific conditions. You've also have some non-specific conditions or findings, if you will. There are some specific disorders that have been identified, both HUS, this Shiga toxin-mediated TMA, that gets better typically with just supportive care and no specific therapy. Atypical HUS, which falls under that category. You obviously can see TTP there, and there's the congenital form. There's the acquired or immune-mediated form, and something called DIC, which is really activated blood clotting and lysing of blood, can give you a picture similar to what you see in a TTP patient, if you will, a lower platelet count, kidney injury, other organ injury, these fragmented cells in the blood. But what you're going to see in the next slide, there's a greater or lesser degree of these findings that help you understand them. The main takeaway you should take from this slide is there are a lot of etiologies of TMA findings, from specific disorders to things that may mimic this, with high blood pressure, vasculitis from autoimmune disease, say lupus. Patients with active or metastatic cancer can have a clinical picture sort of like this. Drugs can commonly do this by injuring the microvasculature. So the TMA is not a diagnosis, but rather a clinical finding. If we talk about this platelet count in the serum creatinine, and that's really going to be central to a lot of what we do and how we analyze what this patient may or may not have before we get, say, ADAM TS13 testing done. But going back many years, it's been very clear that the level of the platelet count and the degree of the kidney injury really can help you predict when a patient's likely to have very low ADAM TS13 activity and be therefore likely diagnosed with TTP. When you don't have that picture, when you're likely to have measurable, or you measure it and find it to be measurable, you're looking for a cause of the TMA that's not related to TTP, another etiology, if you will. And the take-home message here is if you look at the patients who were eventually found to have severely deficient ADAM TS13 activity, so less than 10% typically, you can see some variation there. But in general, the platelet count is going to be lower, typically far less than 30,000, usually less than 10,000. And that's exactly what you see here. In the patients who were eventually found to have the severely deficient ADAM TS13 activity, or TTP, you can see the kidney injury is there, but it's quite moderate to mild. It's not as severe. If you look in that far right column where you see the patients who were found to have measurable or non-deficient ADAM TS13 activity, you typically will see a higher platelet count and greater degrees of renal injury. And that's what really every group showed here. So when you see greater degrees of renal injury and a higher platelet count, you're thinking less of TTP, you're thinking of other causes. Atypical HUS is certainly one of them, but there's other etiologies as well to think about. So this all sort of starts with a case presentation, and so I'll sort of take you through it. And this is work done by Shreya Agarwal, who was in her training as a pediatric hemostasis fellow when she did this work. She's now on faculty at UC San Francisco. But this patient presented with recurrent TMA episodes. So again, low platelet count, fragmented cells in the blood, kidney injury, but having multiple recurrent episodes, 2005, 7, 2011, 2015, 2020. And on the right, you can see a typical sort of CBC that she presented with. And the nomenclature here is what physicians use, and that 9.1 refers to the hemoglobin, the 4.5 is the white count, and the 10,000, or the 10, is the platelet count there. So each one of her episodes were associated with renal failure and the need for hemodialysis. She had plasma exchange therapy, but was found to have on numerous occasions normal ADAM TS13 activity. So this is not a congenital or immune-mediated TTP case. So what you have here is a lower platelet count, but also greater degrees of renal injury. So it's a bit perplexing. It's not quite TTP or AHUS. And what's very important to note here is her last two episodes occurred while she was on eculizumab or rabulizumab. So those are drugs that will block your complement system. And to have a TMA episode, if you're an AHUS patient and you're on one of those medications, is extremely rare and raises some questions as to really, is this disorder mediated by complement dysregulation? So right off the bat, the concern here was this woman does not have a complement-mediated TMA or AHUS. What also became a little bit atypical for her is she presented a little bit later in life, which can happen. But in 2 prior pregnancies, she had no complications, and it's very common for pregnancy to be a trigger for both TTP as well as AHUS. Um, Typically, postpartum, you'll see women show up with lower platelet counts, kidney injury, and that's when a diagnosis can be made. So we saw her and sent out genetic studies to the University of Iowa, who does all these renal TMA studies for us. And we'll talk about how this panel developed. But she had a genetic study that showed a pathogenic variant of the plasminogen gene. So one that's not associated with complement regulation, not involved in TTP, raising the question, should she be on a different treatment? Complement blockade therapy isn't working. What about anticoagulation therapy? Should she be getting plasma infusions or these plasma concentrates of plasminogen? So this is really the beginning of starting to understand, is this something different or new that we're seeing? And plasminogen's primary role is, as you can see here at the bottom, is cleaving cross-linked fibrin. So the formation of a clot, if you will, and lysing it. It's meant to keep in balance clotting and lysing in the body. So your body clots where it needs to, but when clotting has occurred, it's resorbed so healing can happen. So plasminogen really has a role in resolving the clot, managing inflammation at some level, but also wound healing. So if someone were to have a defect in plasminogen, it would make sense that they would have a predisposition, if you will, to clotting. Now, I should emphasize that maybe didn't make it clear that she does not have she has one gene that's abnormal or mutated for the plasminogen and another normal gene. Roughly at the same time, Nishant Tiwari, who actually was a medical student at the time and now is at one of our USTMA sites, the University of Oklahoma, doing his fellowship, reported something similar. So it was an older woman who presented later in life, no problems during pregnancy, but a lower platelet count, greater degrees of renal injury, and raised the question, is this something, this is the way they put it, is bridging both TTP or a complemented TMA HUS, or is this potentially something novel? So really along the same lines that we saw, and it's nice to see a different institution see something independently and sort of confirm what you've seen. This slide's a little bit, I think there were supposed to be some animations here. We'll try to get through this though. So extremely rare disorder when patients have both genes mutated, so a homozygous mutations of the plasminogen gene. They don't develop clotting. This is an extremely rare disorder. Only 12,000 cases are thought to be in the world presently. It's interesting to note, and this will come back to this, there's a female predominance. They get these lichenous plaques, lichenous conjunctivitis as described. You can see in the pictures, it's sort of a yellowish plaques on the mucous membranes. It can be in the eyes, it can be in the pulmonary system, the urogenital tract. And these are fibrin occlusion, fibrin accumulations, if you will. And when these patients are treated, eventually as with plasma or as plasma concentrates, these will resolve. So the hallmark of this disorder, when both genes are mutated, is you get these plaques throughout the body. But again, no clotting. And what you don't see there was some mouse model data. So Dr. Wolberg's group at the University of North Carolina, really one of the experts in plasminogen, create a mouse model and looking at when you lack plasminogen compared to when you have normal plasminogen protein function and trigger the animals to develop a clot. Do you get more clotting in the mice that don't have plasminogen? And the answer was no, there did not seem to be a difference. The carrier state when patients are heterozygous is thought to be an asymptomatic carrier state. So nothing's been reported, but estimated to be about 1 in 400 individuals in the UK, maybe higher in areas with consanguineous unions, patients who are related or are getting married. But again, no known clinical manifestations to date, although this may be, we suspect, one of them. So there's a gene panel we get from certain labs we use at the University of Iowa, and you can see Richard Smith here, the senior author, back here in 2014. But how are these panels developed? So what they did was take 36 patients with a clinical diagnosis of AHUS. And remember, back then, the clinical diagnosis did not involve genetic testing. It was a low platelet count, thought to be greater degrees of renal injury. These patients were lumped together and studied for mutations that were present. The most common one found was a factor H mutation, which is well known to play a part. It'd be the most common genetic mutation found in patients with HUS, but right after that was the plasminogen gene. So it was initially lumped in with these complement-mediated, complement active proteins, although it was identified right off the bat that this does not seem to have any complement function. But for this reason, it was included in most, and it is still today included in these HUS genetic panels. So fast forward a year later, we've had this experience. We're wondering what's going on, and I'm asked to see another patient. I got a call from a doctor at the Cleveland Clinic. It said I have a 64-year-old female. I think she's got atypical HUS. Sent some records, talked to this physician. I said, I don't think this is HUS for the same reasons that first lady. It sounded very similar. I said, I'm certainly happy to help. Let's see her. So we brought her down in remission and talked with her. If you talk with her, she's had 4 episodes, TMA episodes over the past 5 years, and she thinks there may be having with an increasing frequency. Multiple recurrent episodes. The suspicion initially was she had what's called an MCP or CD46 mutation, which is a form of a genetic mutation found in a subset of AHUS patients that are known to have recurrent episodes, but they tend to be mild and self-limited and get better with supportive care. That certainly wasn't the case with her. She had renal failure. She needed dialysis in 2 of these 4 episodes. She was treated with plasma exchange, steroids, always recovered though. And that was also unique about this cohort of patients. Despite the renal injury, they were recovering over time. She also had normal atom tiostatin activity, excluding TTP, and she also did not have problems with pregnancies. So looking at her genetic studies, you don't see the previous frame that got cut off, but she did not have any other known causative mutations. And it's very complicated to understand how these things are reported, but there are genetic studies that are used, models are used to predict would they be damaging, meaning would they create a dysfunctional protein, as well as clinical reports are put together. Because there was not a lot of information, she was reported as having a genetic mutation of plasminogen, but listed as VUS, a variant of unknown significance. So the significance wasn't known. Essentially not enough information known on it. But now we've got certainly a pattern with both of these patients having plasminogen variants, having these recurrent episodes that don't seem to be consistent with TTP or AHUS or another form of TMA. Let me go forward once, then we'll go back. So we looked back on our registry to find the entire series, and what we indeed saw was 3 additional patients. And since that point, we've identified 3 additional patients of all females with varying platelet counts, varying degrees of renal injury, but end-stage kidney disease presentation. But except for one, all these patients are recovering their kidney function. So again, we're seeing this recurrent pattern of kidney injury that's recovering. There's some interesting work. We've got some help from a Nikolai Pose at St. Louis University looking at what's called structure function. What they can actually do with taking a computer is say what this mutation is going to do to the protein function. It's extremely complex, and I barely understand it. But simply put, you can see where this red line is. In 2 of our patients, the 2 that I described clinically, had mutations in this area that is known to bind the protein it's going to cleave. So fibrinogen or fibrin that's cross-linked. This is the area, the red circled area is what binds it. So it's able to cut properly, it just can't bind it, leaving you with what we think is a functional deficiency. So you might have a normal amount of plasminogen, it's just not functioning normally and may lead to the same clinical picture. So with that, I'll stop and pass it on to Yazan for the next presentation. Thank you.
Hello, everyone, and thank you for joining us today. And thank you to the USTMA for the invitation to give this webinar, as well as thank you to my colleagues for their wonderful presentations. I'm Yazan Abu Ismail. I'm an associate professor of medicine at the University of Utah. And today, I would like to talk about the most recent research updates that address the therapeutic advances in immune TTP. And these are my disclosures. There's certainly a lot of research that is happening in the world of TTP, which is great. And there's a lot of different novel approaches that are being studied. And today I want to focus on those that have had clinical evidence. So the therapeutic advances that have clinical trial data and how this could impact the treatment of TTP, as well as research in the future directions. Before I begin, I think it's important to highlight the pathophysiology of TTP as it relates to how treatment works and how the mechanisms of different therapeutics are effective in the management of TTP. My colleague, Dr. Sukumar, already sort of went over the pathophysiology, so I won't be too redundant here. But very briefly, to just kind of recap, we first have in a normal individual who does not have disease, the ADAMTS13's job is to cleave von Willebrand factor and allows for normal blood flow. However, in immune TTP, there are autoantibodies that either increase the clearance of ADAMTS13 or inhibit its function. And as a result of that, we can see that this leads to a severe ADAMTS13 deficiency, which ultimately leads to the formation of ultra-large von Willebrand factor multimers, which together cause increased platelet activation and aggregation. And when that happens, this leads to the formation of microthrombi, or blood clots in the microvascular blood vessels. And as a result of that, this leads to the destruction of red blood cells, or what is called microangiopathic hemolytic anemia and the hemolysis that we observe, as well as end organ dysfunction that can affect various organs. Most critically, this would include the brain and the heart, as you can see in the histopathology slides here. Now, knowing this pathophysiology in mind, that helps us understand what we need to do to treat this disease. So here you can see the different ways that the therapeutics are effective. The standard of care includes plasma exchange, which repletes deficient ADAMTS13 and also eliminates the pathologic antibody, corticosteroids, which suppress the formation of antibodies, as well as adjunctive treatments that include rituximab, which inhibits B-cell lymphocytes from producing the antibody, and caplacizumab, which was approved a few years ago, that inhibits the interaction between von Willebrand factor and platelets, and thus prevents the aggregation as a result of the ultra-large multimers. And under investigation is recombinant ADAMTS13, which is another novel therapeutic. So the novel therapies that I want to discuss today are caplacizumab and recombinant ADAMTS13. I will be focusing more on caplacizumab because we have very recent data that just came out in ISTH, which is the International Society of Thrombosis and Hemostasis conference that happened a week ago. And so we have some great updates to share. So a brief recap here is that caplacizumab was first approved for immune TTP in 2019 after the Hercules and Titan trials, and is recommended by the ISTH guidelines to be considered as an upfront adjunctive therapy for immune TTP in addition to plasma exchange and corticosteroids / immunosuppression. Now, the benefit of caplacizumab was demonstrated in these trials in terms of the shortening of the duration of hospitalization, as well as a faster time to normalization of the platelet count and thus disease response. Keeping in mind, however, that caplacizumab is also associated with a bleeding risk of about 2 to 3%. However, most of the time, this is a mild or minor bleeding and does not require drug discontinuation or an intervention in that case. And CNS bleeding or central nervous system bleeding is extremely rare with caplacizumab. Recombinant ADAMTS13 is a novel therapy that was approved for congenital TTP and not immune TTP. And the difference is that congenital TTP is due to a hereditary mutation that leads to a severe deficiency in ADAMTS13, while in contrast, immune TTP is an acquired disease that is caused by an autoantibody. So these are different disease entities. And right now we have the approval for recombinant ADAMTS13 or Adzynma for congenital, but it is still under investigation for immune-mediated TTP. A recent update that we got this year is additional data on caplacizumab, and this study was called the CAPLA 1000 project. And this is very useful and very helpful data because it provides us with the largest sample on caplacizumab to date. With the clinical trials, the Hercules and the Titan trial, in addition to the positive outcomes and the shortening of the duration of the disease, however, there wasn't a mortality benefit that was demonstrated, meaning it didn't seem in those study populations that death was impacted. However, there was interest in further studying this outcome in subsequent analysis. And there was a subsequent analysis that pooled the two studies together and did demonstrate a mortality benefit. But now we have a much larger data set, which is the CAPLA 1000 project. This was published in the Lancet eClinical Medicine a few months ago this year. So this is brand new data. And in this study, they had 1,015 patients who were treated with caplacizumab in addition to standard of care compared with historic controls. So these are patients who were treated with plasma exchange and steroids, some with rituximab, some not, but not caplacizumab. And so with this analysis, what the authors found was that there was, in fact, a survival benefit. They demonstrated a 98.5% versus 94% in the caplacizumab arm versus the control arm, which met statistical significance. So with this large study sample, there was a survival benefit that was demonstrated. And in addition to that, there was a significant reduction in other very important outcomes, including disease exacerbation, disease refractoriness, the number of plasma exchange sessions, as well as the time to response. So the authors concluded that the early addition of caplacizumab to plasma exchange and immunosuppression significantly reduced unfavorable outcomes, including death, as well as alleviating the burden of care related to immune TTP. Now, there has been interest in finding ways to minimize or even forego the use of plasma exchange, to use these novel therapeutics as a replacement rather than an adjunct to plasma exchange. And many people might wonder why. Why would we want to look at something else when we have a treatment that works and is effective? And the reason is that there are several concerns with plasma exchange, including delays as well as complications. And if you're a TTP patient yourself, you may recall the process of having to wait for someone to place the catheter and having that big catheter for a long period of time, and the process of plasma exchange and sometimes requiring ICU admission and so forth. So typically at a tertiary hospital, a tertiary referral center, the process of plasma exchange requires the placement of a dialysis catheter, often requires ICU admission in terms of personnel who could place that catheter, requires personnel to be available to initiate the plasma exchange itself, which needs staff and equipment, as well as the availability of plasma products. So that's in terms of access to care. And all of these processes can sometimes be associated with significant delays depending on the setting, including at tertiary referral centers or academic centers, not just in the community. In addition to delays, there's concerns about the complications. There's about a 10% reported rate of different complications associated with plasma exchange, although most are mild or moderate. These include hemodynamic changes such as a vasovagal reaction, hypovolemia, or a transfusion reaction from FFP, which is the plasma product used in plasma exchange, as well as catheter-related complications such as thrombosis or blood clots in the catheter, infections, and then there could be different laboratory or metabolic derangements associated with plasma exchange. In addition to that, it does alter the pharmacokinetics of different treatments that we use, such as rituximab, so it may clear it off. And the requirement for longer plasma exchange is also associated with a longer hospitalization, which on its own is a reason for complications sometimes. So there is interest to try to forego or minimize this treatment, and that's what recent studies have been looking into. And so I'm excited to share that the Mayari trial, which has been going on for a few years now, we have the first results that were reported at ISTH just a week ago, fresh from the oven. And this was a phase 3 open label single arm trial that evaluated the efficacy and safety of caplacizumab and immunosuppression, but without any plasma exchange. So this is a very brand new way to approach this disease. This is a kind of practice shifting type of study. And it's great to finally have results to evaluate how safe and effective of an approach it is. In that study, adults with initial or recurrent TTP were included, but those with severe end organ complications, such as severe cardiac complications or neurologic complications or renal disease, were not included, or those who were bleeding. The primary endpoint was achieving clinical remission without plasma exchange. And then secondary endpoints that were evaluated included clinical remission with or without TPE, or how much TPE was how many people required TPE, the time to platelet recovery, refractoriness exacerbations, relapse, death, and adverse events. And what that trial showed, and we'll go to the next slide, is that, so they included 46 patients, and a 93.5% achieved clinical remission without TPE. That's an overwhelming majority, and that's quite an impressive result there. Those who required plasma exchange because of refractoriness, meaning they were not able to achieve a remission, so there were 2 patients that required salvage plasma exchange. So a small number who did eventually require it. The time to platelet response, as you can see in the bottom photo, it was 4 days. So this was a pretty quick response to achieve platelet normalization. And 75% of patients achieved the platelet count response within 5 days. In terms of adverse events that were attributed to caplacizumab, there was a 48% rate of different adverse events reported, but those that were severe adverse events was only 6%. And the authors reported 0% bleeding and 0% deaths. And this is a preliminary conference result. Of course, it is expected to be followed by a full peer-reviewed manuscript with time. So this is kind of our first view of what the Mayari trial showed. In addition to the Mayari trial, additional data was presented at ISTH, which is real-world data from Austria. In that study, there were 31 patients, so it's also a relatively big patient sample. However, in this case, the patients also, the authors included those who had severe organ dysfunction, unlike Mayari trial, in which these patients were excluded. So in this study, they were included. And what the authors found was that there was a very quick improvement in platelet counts, as well as improvement in organ dysfunction, and a very low rate of exacerbation or requiring additional TPE. And of those who did not respond, so there were 5 patients who did not respond, 3 of them had alternate causes, such as viral infections, that were the reason, or that authors believe were the reason for the lack of response. So taken together, these two updates from ISTH provide us with an additional large body of evidence that, and please go to the next slide, an additional body of evidence that demonstrates that caplacizumab and immunosuppression without plasma exchange is a safe and effective treatment in achieving clinical remission for the majority of patients with immune TTP, and with particularly those who do not have severe neurologic and cardiac impairments as demonstrated by the randomized controlled trial. So this was effective, it was rapid, and it's a very feasible approach, albeit it requires close monitoring to make sure that patients may require salvage TPE in case the treatment is not effective in the minority of patients. And safety profile was good in the randomized controlled trial with no new safety concerns identified. And so this is definitely a very good new data to have that provides us great evidence to support a brand new approach in the management of TTP. And this has the potential to be a practice-changing trial. Now, in addition to caplacizumab, so going back to my earlier diagram, there is interest in using different approaches, such as recombinant ADAMTS13, which is approved for congenital TTP. And recombinant ADAMTS13 is of interest in immune TTP because it is postulated that it can lead to immune complex formation that may saturate the autoantibody, and by doing so, promote the clearance of the autoantibody, and then replete the ADAMTS13 that is deficient, and by so treat the disease. So this is a promising upcoming treatment for immune TTP without plasma exchange. It is currently under investigation in a phase 2b trial, so we don't yet have data about it. And when that trial, it is being investigated with minimal to no TPE. So hopefully in the future, once enough patients have been enrolled and analyzed, we'll have data about it. So with these updates, to me, it seems like there is a changing landscape in the future management of immune TTP. There's interest in making the treatment of immune TTP plasma exchange free. And by doing so, patients do not have to go through the process of getting a catheter and remain in the hospital or be subjected to the complications of TPE. And ultimately, the hope is that that improves access to care, early treatment of TTP, as well as improve outcomes as a result of that. There is also future directions in looking at other treatments, such as novel methods of immunosuppression. Immunosuppression is a key component in the management of immune TTP, especially those who have relapse. And currently we use rituximab as a first-line immunosuppressant. However, there is data to support the use of other immunosuppressants, and as well as different approaches in terms of which aspect of the immune system we are targeting in order to treat the disease. And this is also something to look forward to in the future in terms of looking at novel therapeutics that address the immune component of the disease, in addition to the recombinant ADAMTS13 or caplacizumab. So my hope is that the main cornerstones in the future of the treatment of this disease are going to be these three big items here, which is immunosuppression, caplacizumab, and recombinant ADAMTS13, which will present to be a practice-changing or paradigm shift in the treatment of TTP. Thank you all for listening, and happy to accept any questions along with my colleagues.
There is one question in the portal about aspirin as primary prophylaxis in TTP patients. Senthil, Yazan, what do you think? I guess prophylaxing what is the first question, and what do you use?
Yeah, that's a great question. I mean, I think that even amongst like us experts, the consensus is a bit divided. I could probably name half of our USTMA investigators who don't routinely do that, and I think I could name the other half who do routinely do it. And so I think it's an open question, one that we don't have an answer for. But what I can, sort of provide is kind of what I've been doing in light of some of the data that we've been finding. And I don't routinely necessarily, have everybody take an aspirin because just like I think Dr. Catalan was alluding to, we're not sure if these events are mediated the same way and if an aspirin would even be helpful necessarily. But if there is any other underlying cardiovascular risk factor for stroke, heart attack, that kind of thing, then I have a pretty low threshold to say, why don't you go ahead and start a baby aspirin? So that's currently what I'm doing. But Yazin, how about you?
Yeah, I mean, I agree with you. I think if there's cardiovascular concerns or comorbidities, it's a reason to consider it. And in addition to that, situations where I've used it is those who have a laboratory or ADAMTS13 relapse without a clinical relapse, meaning that their ADAMTS13 is low. However, they don't have a TTP episode as evidenced by low platelets and organ dysfunction. And in those patients, particularly those who've experienced symptoms, vague neurologic symptoms, such as maybe headaches or fatigue or so on, I've considered the use of aspirin in that situation as well.
Good. I think one thing I would emphasize, we talk about prophylaxis for heart disease, heart issues, based on what Senthil had told you. But I think also to remember in hospitalized patients, once the platelet count is above 30 or 50,000, you want to be careful about DVTs and that routine DVT prophylaxis as well, as patients with TTP can still get the more traditional blood clots, if you will. I will ask Senthil a question next to say, is it common to have prophylactic treatment with before ADAMTS13 is low? So someone's saying they've had episodes every 2 years and considering a protocol for just doing rituximab on a regular schedule, disconnected from ADAMTS13 measurements. What do you think, Senthil?
Yeah, it's a good question. And I think that the strategy that myself and my colleagues tend to employ the most often in terms of trying to prevent those relapse events is just real frequent monitoring of that ADAM TS13 activity so that we can be really intentional about when we're giving that prophylactic rituximab. Yeah, I'll say 95% of the time it doesn't have any side effects or symptoms, and it's pretty well tolerated, but it still does suppress your immune system. So if we don't have to do it, we'd rather not do it. And so I think a lot of us use that cutoff of 20% to kind of help guide, okay, as soon as you start getting close to or dip below that 20% level, let's go ahead and do another course and not wait for a clinical relapse. Um, but that's the approach I think we tend to use as opposed to just kind of doing it regardless of the ADAM TS13 level because we want to just be mindful of those effects long term too.
Right. You don't want to disconnect the preemptive treatment from the activity, which tells you what your risk is. Yazan, I'll ask you the next question. There are two questions, kind of, I'll pull them together. What does saturate autoantibodies mean? Maybe that's
Yeah,
one.
that's a,
And
yeah.
also, are you trying to stop and phase out plasmapheresis? I think those two questions might go together.
Yeah, so for the first question, so saturating the antibody means that we're, in this case, I was referring to recombinant ADAMTS13. So the concentration is high enough to basically bind all of the antibodies present. So basically you're consuming them and getting rid of them. And by doing so, there's no antibodies left that would target any additional ADAMTS13. So the ADAMTS13 is high enough to overcome it. And I forget what the other question was.
I'm trying to get rid of plasma exchange in TTP. Is that the goal?
I think for many of us and for many clinicians and researchers that is a goal because there is benefit in foregoing plasma exchange due to the delays it can be associated with, as well as some of the complications it can cause. That doesn't mean it's going to become something that's unavailable or not useful. There will always, no matter what, be a utility for plasma exchange, but it would be nice to minimize it or not make it an upfront thing sometime in the future.
And I'll just kind of, oh, go ahead.
No, go ahead.
Well, I was just going to add on, I think it's less so that anybody has an agenda in particular against plasma exchange as a procedure or as a modality. And I think it has to deal more with, it's just such a highly technical, specialized, and invasive type of treatment. Because someone's putting a line in either your neck or your groin. And so it requires specialized people to put in that specialized access. And then you also need specialized personnel to actually do the ins and outs of the procedure itself. And as a result, not everyone can give or do plasma exchange. And that historically has resulted in a lot of delays to treatment, and some of the mortality that we see in the modern day is because people couldn't get to a center that can do plasma exchange fast enough. But now that you have, potentially an IV infusion with the recombinant, or just an injection with the caplacizumab, that kind of opens up the door for a lot more people getting treated in a expedient manner, which without having to rely on these specialized roles as much. You still need a physician who knows what they're doing with these medicines, but I think it's a good thing overall. Yeah.
I'll ask you, Senthil, one question. This is a good continuation of your presentation. I think we have time for at least one more question. And it says, considering there may be continuous or residual effects or long-term complications from the TTP event, would prolonging the treatment help prevent these sequelae? And I think it's a good chance to comment on, is there a distinction between the acute event and long-term, and when do these things happen?
Yeah, it's a great question. And I think, what I was trying to highlight too in some of my talk is the trouble is with some of these events is that they're happening during clinical remission. So, I think Dr. Abu Ismail's talk was very well illustrated, kind of how those microthrombi form in the acute setting, and they kind of show how that damage occurs. And most of our treatments for TTP are really, for the acute treatment of TTP, are really focused on preventing those microthrombi from occurring. But when you're seeing, potential complications long term, and there's no microthrombi there to fix, that's the reason that we're not using some of these acute therapies over a long period of time to try to prevent these long-term complications, because there's no microthrombi, at least that we're seeing, in our peripheral smears and the other tests that we have to be able to kind of measure if this is happening or not. And so that's why we don't use it, because it's probably not going to really be effective if you're not forming those microclots very actively. Yazin, I don't know if you have thoughts as well.
Yeah, and just one more small thing to add is, it's a really good question in terms of, there are long-term sequelae that are serious and we want to prevent them. And what I would also say is one way to address that is not necessarily extending the treatment, but rather expediting the time to response. So there is interest in or merit in saying that using therapies that are adjunctive that will make the time to recovery faster, meaning there's a shorter exposure to the microthrombi and their effects, that this could potentially minimize long-term sequelae, but this hasn't been studied in this fashion yet.
And I think we have time for one last question. Maybe I'll just answer it. I'll have some fun here with you guys. And asking about new treatments, Cablevy, recombinant adenosine, rituximab, prednisone. Have you noticed a lower relapse rate in TTP patients? And I think yes or no is the answer. It's not clear to us if we're preventing with this preemptive approach of treating before you drop your ADAM-TF13 activity to prevent a relapse. It's not clear if you are preventing or delaying a relapse of TTP. That's sort of an active question. But certainly by preventing the drop below 20%, you're lowering markedly that risk of recurrence. So a good question. In some, it's preventing permanently. In some, it's delaying. And we just don't know it because most patients prefer the preemptive approach than to being at risk for relapse. And with that, Claire, are we at time here? Do we have to stop?
We are. Can you hear me?
Yes.
Oh, good. Okay. I don't know what happened there, but yeah, we are actually at time. For anybody who asked a question, didn't have it answered, I will work on getting answers for questions and reaching out if possible, or we will work on having more of these sessions available. These recordings, again, will be posted on our website With the permission of the physicians, I will also post the slides so we have those with the proper attributions on them. And I really appreciate everyone attending. I hope to see more of you at more of our events in the future. And thank you so much to our physicians taking the time out of their day to be able to do this, especially on a Friday evening. So thank you all.
Thank you, Claire.
Thanks, everybody.
Thank you.
Thanks,
Thanks,
guys.
guys.